Good morning. I'm Jeanette Mladenovic, Executive Vice President and Provost at Oregon Health and Science University. Welcome to the 3rd Annual World Congress, Ultrasound and Medical Education. In this room and at this meeting, we have some of the most experienced, knowledgeable experts in the world who are working with point-of-care ultrasound. Throughout this conference, we'll ask you to consider the potential applications of point-of-care ultrasound as an extension of your hands and your clinical skills, and the benefits and limitations to its use, both in care delivery and healthcare education. We hope that there will be many tough questions asked over the course of the conference, and that a robust and vigorous discussion of the roles of point-of-care ultrasound will continue in academic health centers and clinical settings across the globe. I'm excited about the possibilities that POCUS provides to improve some of the fundamental ways we practice medicine and take care of our patients. Just think, what if you could diagnose a pneumonia or heart failure in the clinic and didn't have to send your patient for an X-ray? What if you could show your patient in real time, not just tell her after a series of tests that she had a carotid plaque? What if you could quickly determine in your clinic whether your patient had a fractured bone, and you could tell if the fracture was aligned after you casted it? What if you could tell intravascular volume better and more quickly than guessing at neck veins or measuring orthostatic blood pressures? What if you could find a low ejection fraction, exclude biliary stones as a cause for abdominal pain, or visualize a fetal heartbeat in a patient who's Mr. Menzies in a remote setting miles from the nearest hospital or clinic? These are some of the scenarios, the what-ifs, that we might envision as we talk about point-of-care ultrasound as a new tool in the hands of providers, as we explore the potential as well as the limits of point-of-care ultrasound over these next few days. These are some of the what-ifs we should think about as we consider how we place this technology into the hands of our learners and our healthcare providers in order to make us better at caring for our patients. But first, let's take a look at our tradition as clinicians, especially as it pertains to the use of our senses and hands. That is, how we use our physical exam to confirm or refute the hypotheses that we generate from our patients' stories and the history we have elicited. Almost 200 years ago, we found a need to expand our armamentarium of careful inspection and palpation with something that could help us try to understand what was going on inside the body at the bedside. Thus was invented the stethoscope. With a stethoscope, medicine had a tool that seemed to be a game changer. For the first time, there was a non-lethal instrument for exploring internal anatomy. Physicians could isolate problems and diagnose patients' conditions even when there were no presenting symptoms. Refinements in the stethoscope have continued, but after 2 centuries, we still just have a tube, some earpieces, and our ability to interpret what we hear. And we know that our ability to interpret what we hear, or even to hear it, may be a far cry from what is actually going on in the patients. The physician's skills were significantly advanced by the addition of the stethoscope to our black bag. It's become a symbol of the healthcare professionals. Students don their stethoscopes as a rite of passage. Clinicians display it for easy access slung around their necks. Students receive hours of training in its use. They learn to distinguish variations in heart sounds, detect bowel abnormalities, assess lung function, and they learn to search for a fetal heartbeat. Patients often see the iconic stethoscope and breathe a sigh of relief that they are being cared for by a learned professional, an individual who knows how to use the tools of modern, or maybe not so modern, medicine to arrive at an accurate diagnosis and treatment plan. After all, the clinician has a stethoscope. However, what we know all too well is that wearing a stethoscope and the hours of training that precedes its use do not necessarily translate into provider confidence, competence, or accurate diagnoses. As clinicians, we have increasingly supplemented the information collected through our hands and ears with an ever more complex and costly array of diagnostic modalities, a plethora of lab tests, MRIs, CAT scans, PET scans, and now genetic tests. Somewhere along the way, with astounding medical and technical advances, we have found it more reassuring and way more expensive to send our patient to the nearest testing facility, sometimes even before we've seen them. We know that expensive is not always better. As the most expensive healthcare system in the world, we know that our health outcomes are not necessarily better. This year, 2014, the Commonwealth Fund ranked the US behind other developed countries, 11th of 11. Yet, many believe that our healthcare system will only change with disruption. The theory of disruptive innovation explains the process by which complicated, expensive products and services are transformed into simple, affordable ones. The term disruptive innovation was coined and socialized by Harvard business professor Clayton Christensen, author of The Innovator's Dilemma and The Innovator's Prescription. In The Innovator's Prescription, Christensen applies the principles of disruptive innovation to the health system, describing precision medicine as a solution to reduce cost and increase personalized care. He has applied the same concept to education in his 2008 book entitled Disrupting Class: How Disruptive Innovation Will Change the Way the World Learns. In The Innovator's Prescription, Christensen states that the purpose of most technologies, even radical breakthroughs, is to sustain the functioning of the current system. Only disruptive innovations have the potential to make healthcare affordable and accessible. So I propose to you that the subject of our conference today holds just that potential, the potential to disruptively change our tradition of practice. Just as the stethoscope revolutionized medicine some 200 years ago, we now have a new game changer, a disruptive innovation in the handheld ultrasound device. Like the stethoscope, POCUS is one incredibly powerful tool right at our fingertips that allows us to look under the skin. And it allows this looking to happen almost anywhere, the bedside, a rural clinic, or any place in the world where care is needed. Just as we saw the mainframe computers of the 1970s that filled huge rooms evolve into laptops and iPads, ultrasound technology has significantly evolved. How does POCUS qualify as disruptive technology? Dr. Eric Topol, the Gary and Mary West Endowed Chair of Innovative Medicine at Scripps and voted most influential physician executive in 2012, speaks often of the disruption that is coming in the practice of medicine. He calls it creative destruction, and he argues that mobile devices and the technology that run them will be the vehicle for transformation. Dr. Topol espouses that, in terms of usefulness, perhaps the most proximal of innovative devices is the handheld portable ultrasound. What once weighed hundreds of pounds can now be carried around like a stethoscope. What's more, sound waves do not hurt or emit radiation. Ultrasound is no CT scanner, nuclear study, or heart cath. Yet major questions remain as to how a sound wave emitting device will improve patient care. Is it feasible? Does the evidence support its use?
This is it. I mean, this has been around since 1816. It's on every picture of anything medical. We even have it now attached to smartphones. It's DNA attached. Everything is about the stethoscope. The stethoscope is a relic. It shouldn't be used anymore. We can do so much better than a stethoscope. And, for example, this high-resolution pocket ultrasound device is an example of how we can do so much better. Why would you listen to lub-dub when you can see everything? So within seconds, literally, certainly a couple of minutes, you can get all the views of the heart. And you can see, here's a normal heart. And And I haven't used a stethoscope to listen to a heart in 3.5 years. So you can see everything you want to see, the valves, the function of the heart, thickness of the heart muscle, the size of the different cavities, everything. And here's a person who has a cardiomyopathy, and you see a whole different picture. You can get color imaging of blood flow, and you can see very quickly that this is something that is a very different process that's ongoing with that person's heart.
Technological advances over the past 2 decades have made ultrasound equipment quite portable, with functionality and image quality similar to high-end ultrasound systems used in dedicated imaging laboratories. Their ability was evident early in the war in Iraq, where casualty rates were lower than in previous wars. Why? In Iraq, the military adopted a strategy of positioning close to the fighting, smaller, leaner, and more mobile surgical teams with the ability to erect a battlefield hospital in less than 60 minutes. Traveling in Humvees with handheld ultrasound machines, portable ventilators, supplies of red blood cells, and an array of surgical tools and pharmaceuticals, the teams focused on stabilizing patients and moving them for further treatment in less than 2 hours. By December of 2004, some 10 years ago now, Sonosite had sold 300 of its portable ultrasounds to the Department of Defense. The Sonosite systems were developed in the mid-90s at the request of the military, which was looking for a rugged, portable system that could bring the benefits of ultrasound imaging to the battlefield. It was critical in triaging patients to the appropriate level of care. More recently, pocket-sized ultrasound devices have been developed by several vendors. In this clip, we see another innovator, Eric Dishman of Intel, a little company up the road in Portland, demonstrate how he might use point-of-care ultrasound. Eric wanted to be here today, but instead, here he is on video, being an active participant and monitoring his own health care.
This is a portable ultrasound. It can plug into a smartphone, it can plug into a tablet. Mobisante is up in Redmond, Washington, and they kindly trained me to actually do this on myself. They're not approved to do this. Patients are not approved to do this. This is a concept demo, so I want to make that clear. All right, I got to gel up. Now the people in the front row are very nervous. And I want to actually introduce you to Dr. Batuk, who's another friend of mine. He's up in Legacy Good Samaritan Hospital in Portland, Oregon. So let me just make sure. Hey, Dr. Batuk, can you hear me okay? And actually, can you see Libby?
Hi there, Eric. You look busy. How are you?
I'm good. I'm just taking my clothes off in front of a few hundred people. It's wonderful. So I wanted to see, does this look the image that you need to get? And I know you want to look and see if those spots are still there.
Okay. Well, let's scan around a little bit here. Give me a lay of the land.
All right.
Okay. Turn it a little bit inside, a little bit toward the middle for me.
All right.
Okay. That's good. How about up a little bit? Okay. Freeze that image. That's a good one for me.
All right. Now, the last week when I did this, you had me actually sort of measure that spot to the right. Should I do that again?
Yeah, let's do that.
All right. This is kind of hard to do with one hand on your belly and one hand on measuring, but I've got it, I think, and I'll save that image and actually send it to you. So tell me a little bit about what this dark spot means. It's not something I was very happy about.
Many people after a kidney transplant will develop a little fluid collection around the kidney. Most of the time, it doesn't create any kind of mischief, but it does warrant looking at. So I'm happy we've got an opportunity to look at it today, make sure that it's not growing, it's not creating any problems. Based on the other images we have, I'm really happy that how it looks today.
All right. Well, I guess we'll double check it when I come in. I've got my 6-month biopsy in a couple of weeks, and I'm going to let you do that in the clinic because I don't think I can do that one on myself.
Good choice.
All right. Thanks, Dr. Batuk.
Thanks, Eric. Eric is the Director of Health Innovation and Policy at Intel. If, as Christensen suggests, only disruptive innovations have the potential to make healthcare affordable and accessible, clearly we must embrace disruptive innovations if we are to meet the triple aim of lower costs, better and safer care, and better outcomes. This, I do believe that the application of point-of-care ultrasound at the bedside qualifies as a disruptive innovation because a complicated, expensive product and service has been transformed into a simple, affordable device that can be put into the hands of students and practitioners, and maybe even patients, across the globe and even in space. So how might point-of-care ultrasound improve health outcomes, enhance patient safety, or decrease our costs? You experts and longtime users of point-of-care ultrasound know much better than I the dramatic examples you see on a regular basis in emergency rooms, hospital wards, or in the field. But as now an experienced clinician of several decades, here are some thoughts that I have. If we were more secure in our physical exam or adept with a simple ultrasound, could we decrease our use of CAT scans? About 70 million CAT scans are performed in the United States each year. On average, that means 1 in 4 individuals are getting a CAT scan every year, and this accounts for 1/4 of the average radiation exposure from all sources. Fewer CAT scans would be cheaper for us and could limit exposure to ionizing radiation, a cancer risk. POCUS is already being used widely in emergency medicine. What about the expansion of POCUS to other settings? Should providers use POCUS in home visits, thus diagnosing and treating earlier and transporting patients with more certainty? What about patients with the most common complaint, a respiratory complaint? A recent Lancet study suggests that in patients with respiratory symptoms, in a single-blind, randomized controlled trial, POCUS was a feasible, radiation-free diagnostic test, which was superior to standard tests alone for establishing a correct diagnosis within 4 hours. The authors conclude that POCUS should therefore be considered for routine use in the emergency department for patients admitted with respiratory symptoms. Just imagine, what if the use of POCUS in patients with respiratory complaints could decrease the use of chest x-rays? 43 million chest x-rays are performed each year at a cost of more than $70 per x-ray. Even if just 1% of chest x-rays were no longer performed due to POCUS of the lung, the savings would amount to almost $48 million, enough to supply 6,000 providers with their own hand-carried devices at today's cost. How about if we could better manage our patients with our most common admitting diagnosis? Acute decompensated heart failure. Kirk Spencer and his team at the University of Chicago have been evaluating the adequacy of CHF treatment by assessing the collapsibility and the size of the inferior vena cava. Both residents and nurse practitioners have conquered this skill with limited training. Now his group is able to show that measurement of the IVC diameter and collapsibility, as assessed by focused cardiac ultrasound, is an effective way to guide management of patients with heart failure. And this results in a marked decrease in 30-day readmission rates and emergency room visits for these patients. Clearly better for the patients and a cost savings. Why am I such an advocate for point-of-care ultrasound? How did I get to this place? I was originally a hematologist and have spent my entire career in an academic health center, teaching students physical exam skills, chairing a department of medicine, rounding with residents, observing the extent of their clinical skills and those of our faculty, and serving as a dean responsible for the next generation of physicians. In my experience on the American Board of Internal Medicine, I finally began to see the disconnect. I knew that applicants for the certifying board could answer a patient question when they were told an S3 was present. I was just not convinced they could ever hear or would take the time to hear an S3 when they were doing their own patient exam. So while knowledge is critical, it must be translated into what we do daily as we care for our patients. And today's medical education needs to align with clinical reality. The traditional physical exam taught in the first 2 years of medical school has changed little in the last 50 years. But what we teach medical students and other healthcare students who perform physicals is out of step with what is seen on the wards and in clinical practice. In a recent Journal of General Internal Medicine article entitled the physical exam and other forms of fiction, Abraham Verghese notes that the two-dimensional rendering of the patient through imaging occupies us more than the three-dimensional reality of the patient. Verghese lists the many good reasons to maintain the ritual of teaching students the art of examining the patient, including hypothesis generation, developing patient trust, and of course, passing the USMLE clinical exam. He states what many of us know all too well, that the kinds of errors that occur from lack of physical diagnosis skills are not easily recognized, that healthcare reform will bring with it a new level of accountability, and that it is unlikely that the promiscuous ordering of imaging and other lab tests can continue to conceal the problem of poor physical exam skills. Can POCUS be the tool added to the new black bag to augment the stethoscope and ensure better exam skills while lowering costs? The Stanford 25, a list of priority clinical skills, and DeGown, a detailed compendium of physical exam findings originally published in 1936 and now in its 10th edition, include bedside point of care ultrasound. We know that even in the hands of the most skilled expert clinicians, our physical exam is not necessarily good enough. As has been shown in previous studies now almost a decade ago, students with limited ultrasound training become more skilled at cardiac exams than expert cardiologists, as is also true of young physicians in training. And now, experts become better than experts. A new study here at OHSU compared the use of handheld ultrasound with physical exam in 250 patients referred for transthoracic echocardiography. Cardiologists evaluated patients either by physical exam alone or by ultrasound augmented physical exam. Once again, even in the hands of experts, that is cardiologists, physical exam identified cardiac abnormalities correctly less than half the time, whereas use of handheld ultrasound markedly improved diagnostic accuracy. Additionally, in patients with no cardiac abnormalities, handheld ultrasound decreased the number of additional tests ordered. So, POCUS added accuracy to experts, decreased the cost of a workup, and more appropriately referred patients to full echo. Why should we care? What is the motivation in promoting point-of-care ultrasound as a new tool to enhance our physical exam? After all, if history taking is the most critical aspect of this art we call medicine, maybe we should abandon the physical exam in lieu of total body scanning or computer-generated algorithms. We could come to this, but is this in the best interest of our patients? As I noted, we have lots of reasons for performing a reliable, careful physical exam. Some conditions can be readily diagnosed by physical exam, such as most skin diseases. The physical exam does help us generate our hypothesis to better direct our tests and understand the results of those tests in order to avoid false positive and false negative conclusions. The ritual of lying on of hands helps establish a personal and trusting relationship that improves care outcomes and is at the core of our professionalism. And finally, in some cases, the most difficult of diagnostic situations, a careful and meticulous physical exam are better than the most expensive of tests. POCUS connects the provider to the patient with real-time data. It should be focused to answer specific questions and not be a replacement for other elements or the physical exam itself. Rather, it should serve as an additional tool to advance the triple aim: less costly, enhanced quality, and greater access. So can we do this better? Can we add to the armamentarium of tools that help us return to the bedside and our patients? I believe we can. POCUS is that new tool, and it is and will disruptively innovate our practices and healthcare education. And this is actually a really good thing. However, it is important to understand what we are not trying to do with the introduction of POCUS into the hands of generalists. Point-of-care ultrasound is not a replacement, nor should it lessen the importance of the history and physical exam. Nor does POCUS replace all of our senses that we use in the physical exam. It is just one more tool, albeit a powerful tool in our black bag. POCUS is not meant to replace detailed ultrasound or to create experts in imaging. As we think of it today, it should be used in a binary fashion to support or refute a hypothesis that we have generated from our knowledge and context of our patient and the prevalence of disease. POCUS is currently heavily utilized in emergency medicine, trauma, and surgical and medical care, critical care. Formal training occurs in obstetrics, gynecology, emergency medicine, surgical critical care, sports medicine, vascular medicine, and subspecialties of medicine. In this conference, we will explore other areas where POCUS could potentially improve training and enhance the physical exam. We may identify uses beyond traditional clinical settings, rural, remote, underserved areas where POCUS could enhance care provision. POCUS has the potential to improve on-site emergency care and to help our emergency medical teams be more effective. POCUS is changing for the better how we teach anatomy and physiology. So I hope you will consider some of these current and potential uses of POCUS throughout this conference, and that as you listen to your colleagues, you find much to stimulate your thinking and many questions to be asked and answered. Thank you for considering this disruptive innovation to our medicine tradition. Thank you.